So this slide shows a picture of what many of you will recognize as the Bennett MA1 mechanical ventilator. Heard about this in some of the talks that were given yesterday. When I was a baby medical student, this was the ventilator that was predominantly in use in the critical care units where I was learning. And another couple of reasons that this picture is in my talk is that number two, I think that with a number of notable exceptions, some of the things that have been major developments in the last 40 years that we can apply in the care of our patients could be used with the MA1 if we were using those today. Obviously, there are some exceptions to that, and the ventilators today that you'll see in the exhibit hall are incredibly more sophisticated than that. And then the third point I wanted to make about the Bennett MA1 is that in my personal opinion, it is the best TV and movie mechanical ventilator of all time because believed breath and the whooshing sound is very evocative. So kudos to the producers. So as I sat down and thought about what were the important things that were developments over the last 40 years, I wrote those down. This is the list of them that we'll briefly go through today. There happened to be 10, but I didn't set out to create the top 10. This is not the Letterman show, just that's how many ended up on the list. And I won't read these off because we'll be looking at them all individually. So one of the, and they're roughly in chronologic order of the awareness or development of these features. First on the list is the recognition of the development and the detection of occult PEEP. You heard a little bit about this yesterday. This was the classic article from 1982, authored by Paul Pepe and John Marini. Paul is pictured there. He's nowadays more well known for his work in out-of-hospital cardiac arrest and cardiopulmonary resuscitation. And the terms intrinsic PEEP, dynamic airflow obstruction, and auto PEEP are some synonyms that will frequently be used in describing this. And it's notable that this original paper was in patients who had obstructive airways disease. But as we know, other patients without airflow obstruction can develop intrinsic PEEP under mechanical ventilation, particularly if the expiratory time is too short for the set rate. Now, one of the things that happened very commonly early in my career when I was a resident in medicine or a fellow in pulmonary and critical care medicine was that I would get a call from the ER doc. He would tell me that a patient came in with a COPD exacerbation who was tripoding and diaphoretic and hypercapnic and in distress, and they intubated him. Nowadays, of course, that patient would receive non-invasive ventilation first and might not have to be intubated. But the problem was that the blood pressure that had been fine originally after intubation, now the patient's in shock, they don't know what to do. So typically I would go ahead down to the emergency department, and as soon as I got there, first thing I would do would be to disconnect the ventilator circuit from the patient's endotracheal tube, sometimes put a hand on the chest and assist exhalation and maybe some volume given, and usually would solve the problem. So the cardiovascular consequences of overdistension are that the ventilator delivers a breath before the patient has completely exhaled the previous breath. There's an increase in intrathoracic pressure, hyperinflation of the lungs adjacent to the heart, which impairs right ventricular filling, decreased venous return, decreased stroke volume, and hypotension is the consequence. Now, these are graphics from that article by Pepe and Marini. And on the right side, you see under the ordinary circumstances, non-obstructed patient during exhalation with the expiratory port open. At the end of exhalation, there's no more flow. And in this case, there's no set PEEP. So the manometer reads 0. But in the case of the severe airflow obstruction where it appears that exhalation has ended, the manometer will read 0, but there's still a positive pressure in the alveolar spaces. And then, as you know, one way of detecting that is to do an expiratory hold at the end of exhalation. And the ventilators can do this automatically for you now or using a feature, but even the MA1, we could have done this manually on the exhalation limb. And that allows these pressures to equilibrate, and now your manometer is going to show you that positive pressure. This is a radiographic depiction of that, where on the right, the patient with obviously has very severe emphysema, COPD, is on mechanical ventilation and is markedly hyperinflated. And you see the so-called vertical heart. And you can imagine that it's very hard for there to be any return of blood to the right heart. They took the patient off of that and just put him on pressure support. The lungs are still hyperinflated. They always will be, but the heart now has regained a little bit more of its natural contour. This old slide shows you a case where a patient is ventilated at a fairly high respiratory rate and has some air trapping as denoted by the failure of the expiratory flow waveform to reach zero. You simply turn down the respiratory rate, and in this particular patient, the auto-PEEP is resolved. So potential consequences of auto-PEEP include hemodynamic instability, barotrauma or lung injury, VQ mismatch, difficulty triggering the ventilator for additional sedation, and impairing weaning. And so this was really something that clinically has been very important in my practice over the years, and that's why it's on the list. Second on the list was really something that we didn't think about in the early 80s when I was just getting started, but that is that even in so-called controlled mechanical ventilation or assist-controlled mechanical ventilation, that the inspiratory work of breathing continues during that ventilation, and we may not recognize that. And obviously, there's been a lot of discussion at this meeting about how this can be detected, particularly sometimes with the use of esophageal manometry. This was, again, a key article, in this case authored primarily by John Marini, shown here. And these are, again, graphics from that article. On the right-hand side, showing you that in patients who are on volume assist control who may not be getting the flow that they feel they need, that you'll see scooping of this pressure time waveform that might be a hint of that. As it turns out, in 1985, there were hardly any mechanical ventilators that had graphical waveforms, so you really didn't have the ability to see that unless you did you added some monitoring. On the left side, they did a study with some volunteers who they gave carbon dioxide inhalation in order to drive their minute volume needs to either 12 or 24 liters per minute. And if they set the trigger sensitivity on the device that they were letting them breathe through at a fairly insensitive level of -5 centimeters of water, in those that needed 24 liters per minute, you saw a major increase in active work of breathing. Likewise, here, if you required them to have 24 liters per minute of breathing, and you set the inspiratory flow at 80 as opposed to 100 liters per minute, you can make a big difference in their active work of breathing. So something that we today still have to recognize may exist, and depending on our ability to monitor for this, we may have to assume that sometimes some of this is going on. Third major development, again, doesn't have any, it's not directly something on the machine, but is related to our practice in mechanical ventilation, is the development and the use of pulse oximetry in patients with respiratory failure. So in the middle of the century, this technology had been developed, but required a giant box that was not practical for use in clinical settings. But in 1980, Biox introduced the first commercially distributed oximeters for clinical use. And by just a few years later, none other than John Severinghaus, the developer of some of the electrodes used for arterial blood gas analysis, called oximetry the most significant technological advance ever made in monitoring the well-being and safety of patients during anesthesia, recovery, and critical care. And then just a few years later, in October 1989, the American Society of Anesthesiology delegates voted oximetry a mandatory monitoring standard in all anesthetic cases in the United States. Interestingly, though, just recently, as I was developing this talk, I looked at UpToDate, the online medical textbook that is frequently updated. and found this comment about oximetry. Despite its widespread use, the value of oximetry has been poorly studied with no trial showing a convincing benefit on clinically meaningful outcome, for example, mortality, myocardial infarction, or resource allocation. Nonetheless, I'm pretty sure that few of us in the room would like to go back to a day where we didn't have pulse oximetry as one of our key monitors, not just in mechanically ventilated patients, but all patients with potential respiratory issues. Now, again, a lot of talk about use of graphical waveforms here today and yesterday, but we take that for granted now, and 20, 25, 30 years ago, we did not have these on mechanical ventilators. And in my mind, these have been incredibly helpful for me and for my patients and for my allied health providers who care for these patients. And I think it is one of the major advances forward in mechanical ventilation. So you can find a variety of things just by looking at the patient's waveforms, you know. This is an older ventilator we have in one of our hospitals where we have a consistent problem with this kind of flow waveform that must represent some problem with the exhalation valve or the expiratory flow sensor. And, you know, being able to look at that, sometimes I've been text pictures of this when I'm at home, and I let the therapist know that either there is or isn't a problem with the patient. We talked about this some yesterday. Some of the newer ventilators have the ability to generate a pressure volume curve for you, a PV curve, so that if you like to use this as a means of detecting inflection points and possibly setting PEEP, you can do that. Back in the day, before the availability of this kind of software on ventilators, we used to do this in this fashion. We had a patient who was paralyzed. Usually we were doing this on patients who were on ECMO and were safe to do this, where we would use a super syringe and a manometer and incrementally inflate the patient and record those values. So a big step forward. It's been shown that in some cases you can use waveforms, particularly the flow volume loop, as a means of detecting a patient who has secretions or obstruction in the circuit and may need to be suctioned. So all four of these patients, this is Gibran and Tobin, all four of these patients had secretions that were cleared by suctioning. These were four other patients that did not seem to have secretions and had more smooth waveforms and lacked that sawtooth pattern. So use of graphical waveforms, very important in my practice. I would say that 99% of the time when I walk into the room of one of my patients on a mechanical ventilator, my eye goes first to the mechanical ventilator rather than the patient. I can tell in a minute a number of different things about how that patient is interacting with the ventilator. Is the patient being ventilated? You know, are they disconnected? Detection of secretions, response to bronchodilators, whether they're air trapping, some cases auto-cycling or excessive triggering effort, low starvation, general evaluation of patient ventilator dysynchrony, and again, if the PV curve is available, being able to detect an inflection point to help set peak. So fifth on this list of what I think may be major developments for me in the care of my patients is the availability of modes of ventilation that are pressure targeted. So the MA1 only had volume controlled mechanical ventilation. But by pressure targeted, I mean such modes as pressure support ventilation, pressure control, and Rob talked about how those can be delivered in a variety of ways, and the dual modes, which we use a lot, and adaptive support ventilation. The touted benefits of these modes of ventilation include patient ventilator synchrony, possibly improved ventilation perfusion matching, maybe less sedation, possible aid to weaning and liberation of the patient. It's generally been hard to prove a positive effect on outcomes of interest, such as mortality and length of time on the ventilator in well-done trials, but it's definitely another option for our use for patients to see if they can be more comfortable and in some ways safe. So I do use it a lot, and I think that was an important development. Six on my list here is the return of non-invasive mechanical ventilation. And no, not this kind of non-invasive ventilation, although I think that there are still some patients who might benefit from versions of a negative pressure mechanical ventilation. But no, we're talking about non-invasive positive pressure ventilation, such as in this case, you see a patient on a BiPAP device using some type of a mask up to and including the helmets that were illustrated yesterday. So we've come to realize that non-invasive ventilation can be very helpful in patients, especially with acute hypercapnic states like COPD exacerbation, very much so in cardiogenic pulmonary edema, selected patients in respiratory failure who have immunocompromised states, and in facilitating discontinuation of ventilation in a number of patients who are borderline in their assessment for ability to liberate, but that you think can get by with a little bit of assisted pressure. For all of these, there's robust scientific data supporting the benefit, and you heard from Dr. excuse me, Nick Hill yesterday, nicely so that made a big in my practice once we could kind of convince the first providers to buy into this. This is one of the early articles published by Laurent Burchard, which was from 1990, I believe, illustrating the usefulness of non-invasive ventilation in a small series of patients with acute exacerbation of chronic obstructive pulmonary disease managed non-invasively without intubation. And then by another decade after that, you were able to do these kinds of multivariate analyses with a forest plot here showing a significant trend toward benefit and outcomes of interest in patients with at least COPD treated with non-invasive ventilation. So now I don't have to go down to the ER so much to deal with these intubated patients. Seventh on my list is the concept and the recognition of the concept of the ventilator-induced lung injury and its effect on our clinical practice. And as mentioned yesterday, some of this dates back to the mid-1970s when Webb and Tierney at UCLA demonstrated that mechanical ventilation of rats at a high airway pressure could cause lung damage that was virtually indistinguishable from what they were seeing in patients with acute respiratory distress syndrome, and that could be partially mitigated by application of PEEP. Then in the 1980s, Ted Kolobau and many others in various animal models, sheep, dogs, pigs, rats, rabbits, demonstrated that ARDS pattern could be both clinically, radiographically, and histologically could be induced by mechanical ventilation at high peak inspiratory pressures and thus high volumes. In the 1980s, Gatnoni and several others showed that by CT scanning, the lungs of ARDS patients were actually heterogeneous. Prior to that, we were assuming that this diffuse pattern we saw on plain AP portable chest x-rays meant that the disease was completely the same throughout, and it wasn't, including some areas of normal appearing lung, which the term baby lung was coined by Gatnoni. And then in 1990, Keith Pickling in New Zealand described a series of patients who had a higher than expected survival with severe ARDS when they were treated with very low tidal volumes and consequent hypercapnia, leading him to coin the term permissive hypercapnia. So going back a ways, prior to the current understanding of ventilator-induced lung injury, our thoughts about the adverse effects of high pressures with mechanical ventilation revolved around barotrauma, such as in this patient who, with bad ARDS, has 5 chest tubes, 3 on the right and 2 on the left. This is somebody sort of before the current era who was referred to our program in like 1990 for ECMO. She had been ventilated for 18 days with high tidal volumes, high PEEP, and high FiO2 as well. And incidentally, she was actually 18 days on the ventilator. She probably would be excluded these days from our program because of the length of time on the ventilator, but we went ahead and did it, and she recovered after 28 days and had normal chest x-ray and breathing room air. So this is the famous, photograph from Donald Kearney's article, 1974, showing the lungs that were explanted from rats, mechanically ventilated in different ways. This rat had 45 centimeters of water pressure per breath for 1 hour at 0 PEEP, and the lung is markedly engorged and hemorrhagic and irreversibly damaged. On the other hand, a rat ventilated for an hour at 14 centimeters of water, a little bit more normal pressure. A lung that came out was relatively normal in almost every way. And then there was an in-between group where 45 centimeters of water were the descending pressure, but 10 centimeters of PEEP were applied. So the lung is still swollen and engorged, but not, as hemorrhagic and badly damaged, suggesting that something we're doing with the ventilator is harming our patients. But really that was to some extent not really paid attention to until for the mid 80s, when all of these animal studies started evolving and emerging that showed that you could induce ARDS just with the ventilator alone. In this case, a pig ventilated for 42 hours that were similar in humans to being ARDS, and a histology on autopsy showing hyaline membranes and influx of inflammatory cells and pattern consistent with ARDS. And then innumerable other studies then followed over the next few years in animals. This is one of the early CT studies published by Luciano Gattinoni there, showing that in ARDS patients in general, you'll find areas of relatively spared, apparently normal lung, and then areas mostly in the dependent regions where there's consolidation, atelectasis, and edema, suggesting that we might be harming these areas with mechanical ventilation. And that's sort of depicted here. Air delivered under pressure is going to go to the area of least resistance, which will be the relatively normal baby lung. But this schematic showing what is presumably this part of the lung is poorly compliant and doesn't get much of the tidal volume. These areas, and this is a scan from one of our patients, these are the areas that we're probably ventilating in those patients. This is the key paper published by Dr. Hickling, shown here, describing a low mortality associated with low pressure limited ventilation with permissive hypercapnia and severe adult respiratory distress syndrome. I would say that was definitely influential on us at the time in my group, where we were already using mostly pressure control ventilation to limit peak airway pressures, and we did that more avidly then, well in advance of the further literature that suggested that this was the way to go. I would recommend to you this article by Art Slutsky from 2015 in American Journal of Respiratory and Critical Care Medicine, which has this really nice timeline showing some of the key developments in the history of our understanding of ventilator-induced lung injury, going back to early recognition of the role of surfactant in babies who have respiratory distress syndrome, which was ultimately the source of the later acronym in adults, ARDS, on up to the ARDSNet trial in the late 90s, early 2000s. Well, this is the well-known survival curves from the ARDS network trial, where tidal volumes of 6 milliliters per kilogram predicted body weight, volume assist control mode, were compared with 12 milliliters per kilogram, showing a significant major mortality benefit in patients who were ventilated with low tidal volumes compared to what was said to be conventional tidal volumes. This has already been shown at this meeting, but again, very important to those of us in critical care, as a very important recognition that sometimes surrogate physiologic endpoints in clinical studies in critical care may not correlate with the main outcome of interest, which in ARDS, of course, is primarily mortality. The 6 milliliter, it just shows you that you can ventilate with higher tidal volumes and improve gas exchange. Kind of knew that, but these patients die at a higher rate than patients ventilated with low tidal volumes, and that's an important takeaway, not only in mechanical ventilation, but some other therapeutic trials in critical care medicine. So number 8 on my list is our process of weaning or liberating patients from mechanical ventilation. I think that has also been a major change during the years of my career in medicine. So I title this Weaning Put to Rest Mostly, Not All the Way. And we'll start this story with Yang and Tobin's publication in 1991 in the New England Journal. That was shortly after I'd been a fellow in pulmonary and critical care medicine. And we spent a lot of hours obsessing over the various indices that were said to predict weaning success at that point, maximum inspiratory pressure, patient's ability to generate a vital capacity, their minute volume that we saw on the mechanical ventilator, and a variety of others. In this prospective study, Yang and Tobin looked at these indices and found that for the most part they all had poor sensitivity and specificity as standalone features. One thing that did seem to work somewhat well was a calculation of the patient's respiratory frequency for a few minutes of spontaneous breathing. And that if you had a frequency tidal volume above about 100, meaning that you had fairly rapid shallow breaths, you had a poor chance of surviving extubation for 48 hours. If you were below 80, then there was a great discriminant value for success. Esteban illustrated that across a variety of different indications for mechanical ventilation, that the total time spent weaning the patients as compared to the total time on mechanical ventilation occupied about 50% of the time. And that was thought to be excessive, and it probably was. He subsequently did a randomized prospective trial looking at intermittent daily breathing trials as a means of liberation versus pressure support ventilation and decremental pressure support ventilation and IMV, and appeared that intermittent breathing trials were as good as, or perhaps better. The editorial that's present in that article, I think, is as important as the trial itself, where Weinberger said that an alternative explanation is that once daily trial of unassisted breathing is not intrinsically superior in facilitating weaning, but rather that daily testing allows earlier recognition of the patient's ability to breathe without assistance. I think that proved to be prescient because a number of the subsequent trials that were done looking at protocolized approach to SBT plus extubation had to exclude up to 75% of the patients on day one, because when they subjected them to a breathing trial, they were ready to be extubated. And so one wonders in these subsequent slides, I'm going to show you whether of those 75% of patients, they would have been subjected to a week or more of weaning if we were using our sort of clinician-directed approach. So the protocol-directed weaning story sort of begins with Wes Ely's group at Vanderbilt, where they did a prospective randomized controlled trial of a daily assessment by either the nurse or the respiratory therapist or both, but not necessarily the physician. And then if they passed the screen, a performance of a spontaneous breathing trial, and then if they passed that, asking the physician whether or not to extubate the patient. And if you look at the patients needing to continue to receive mechanical ventilation, there was an early and very significant benefit in those patients who were in the protocol group as opposed to the ad hoc physician-directed weaning. And then that was able to be replicated by Koloff here and Merelich. And so that led to, within a few years, strong recommendations from essentially all of the societies of critical care and respiratory medicine, recommending that we apply this approach to weaning, at least in the short-term acute care type of patients that constitute the majority of mechanically ventilated patients. Ninth on my list then is in general attention to the positioning of the patient during mechanical ventilation. Again, this is something you could do with the MA1 because it has nothing to do with the ventilator itself. It's how we manage the patient. First would be the notion in the early 90s that was sort of shown in several studies that pulmonary aspiration of gastric contents in patients receiving mechanical ventilation was probably lessened to some degree if we elevated the head of the bed to 30 degrees or so. We had known since the early 70s, and studies done by Johansson and Sanford, that the main cause of ventilator-associated pneumonia is bacteria that come from colonization of the upper airway, the oral pharynx. And so this was an important recognition. But maybe of even more importance to those of us who care for the most seriously ill mechanically ventilated patients is the fact that prone positioning, which we'd known for a number of years, seemed to physiologically benefit patients in terms of oxygenation, does appear, at least in one very good prospective trial, to demonstrate a benefit on mortality. And I don't know whether you can see it here, but this is a patient of mine a number of years ago who was on mechanical ventilation for ARDS. And in the supine position had a PO2 in the high 50s on 100% FiO2, and same mechanical ventilation settings. Put the patient prone, and then 5 or so hours later, same exact ventilator settings, including 100, has a PO2 in the 200 something. There's some physiology that relates to this. In particular, the mortality benefit may have less to do with the oxygenation change and more to do with the stress on the lung that is to some extent relieved beyond the scope of this talk. This is the big study published by Guerin a few years ago in the New England Journal, which was a large prospective randomized trial. One of the things that differed a bit from some of the earlier studies was that this was applied very early in the course of ARDS and for at least 16 hours per day of prone positioning, which I think even in our own hands, we had trouble getting our heads around that in years prior to that. And it showed a very nice benefit in survival for those patients who were prone. And then finally, finally on the list is the development of high-flow humidified nasal therapy or high-flow nasal cannula. Steve spoke at length about this yesterday. And those of us who survived and participated in care of patients during the pandemic are very familiar with the massive amount of use of high-flow nasal therapy that we did. Again, you won't be able to read this, and this is, I picked this as the slide to accompany this development because the European Respiratory Society Clinical Practice Guidelines with respect to use of high-flow nasal cannula as opposed to conventional oxygen therapy or non-invasive therapy in a variety of conditions, hypoxemic respiratory failure, hypercapnic respiratory failure, extubation, prevention of reintubation, a number of different things. They are, I would say, the most liberal recommendations supporting high-flow nasal cannula as compared to the ATS or the SCCM guidelines. But these alone sort of illustrate how far high-flow nasal cannula therapy has penetrated into our practice. And I would say that this has most definitely been a major development for me in the care of my patients. So a number of things haven't been mentioned, many more than are on this slide. And some of these may be your pet features. But these are the things that I found most important for me in the care of my respiratory failure patients, and I wonder what you all have found important. Thank you for your attention. Questions if there are time. Yes, Graham. I said honorable mention because some people that may be one of their faves. We talked about this in the small groups yesterday, where I was at the Hamilton area, and it happens that the three large hospitals that I work in and our group works in, we have virtually all Hamilton mechanical ventilators, so we have that capability of using ASV. And I would say, as I said yesterday, probably 95% of all of our patients are ventilated either in adaptive support ventilation or APV CMV, which is the PRVC equivalent that on the Hamilton mechanical ventilators. Our post-op heart patients, we sort of evolved over the last couple of years. We have two hospitals that do cardiac surgery, and pretty much all of our patients routinely now come out and are placed on ASV. Not for any major reason, but we find it easy. And, you know, kind of as Rob has mentioned, the ventilator does a lot of the work for us. All the monitors are there, so we feel comfortable. But there are patients I won't ventilate in ASV, and most of them ARDS patients. Steve, I think you were first. Okay, Jeff. Yeah, you know, Rob showed us what's coming in the future. I thought it would be most valuable for me to look at what's happened during the period of my career. And I think, you know, similar to what Rob said, you know, smarter and smarter mechanical ventilators that ultimately will take a number of the decisions out of our hands based on, you know, intense monitoring of the physiology and guidelines based on things that we know work. So, you know, the ventilator will tell us the tidal volume that's best for that patient and the flows and the settings. So I think that's, you know, these feedback things are inevitable. Obviously, we've been held back by restrictions by the FDA, but one day we'll have all that. Well, you know, I think as described here in the very first talk yesterday by Ehab, I mean, ways of looking, better looking at what effort the patient is putting in, which is really hard to do with just the ventilator waveforms alone. Perhaps the distribution of ventilation and stress, maybe the EIT is potentially a way to go. I think those sort of advanced forms of monitoring will probably come along. Somebody will probably come up with something that's easier and less invasive than esophageal manometry. And so I think those will be paramount in the future. I think, you know, looking, it's funny because you know, sometimes as I talk to respiratory therapists and teach them at the bedside, you know, in the hospitals, in my mind, the thing that's had the most beneficial impact on our patients with ARDS, just one form of respiratory failure, has nothing to do with the ventilators. Prone positioning. Number two is low tidal volume. Used to be number one, but you know, once we learned, and unless there's a subsequent trial that disproves that thesis, you know, you got to think about the whole patient, not just what's going on with the blower. Well, thank you again.
Steve, we might need to